Hello everyone and welcome to another session of next Saviours Essential Question Series for NEET PG 2025. There is no paper where there is not a question related to GCT or important benign tumors. And today we are going to talk about the differences in between the epiphyseal tumors which are usually kept in your examinations. A bone can be divided into various regions based upon the specific histological patterns, and the ends of the bones are to be identified as epiphyses. You know, some of the tumors specifically are growing from the metaphyses, some of them are diaphyseal tumors, but there are two tumors which you have to remember, which are the part of the epiphyses which are originating from the epiphyses are the GCT, that is giant cell tumor, and the other one is chondroblastoma. There is another name which is given to both these two tumors. The GCT is also known by the name of osteoclastoma because there is increased activity of the osteoclastic cells leading to the lytic lesions of the bones. And chondroblastoma is also known by the name of Codman's tumor. So you see, don't get confused with the name Codman triangle because Codman triangle is a feature of osteosarcoma. Codman tumor is the name which is given to chondroblastoma. So let's start with the differences one by one. The first one is obviously the age. You see, the giant cell tumor usually affects the individuals after the skeletal maturity is achieved. That means beyond 20 years of age. While the chondroblastoma usually affect the individual of less than 20 years of age. Now, majority of the times in your NEET PG or FMGE examinations, this clue is more than enough for you to answer the question. How? Imagine if there is an X-ray where there is a growth plate is still visible and there is a lytic lesion in the epiphyseal region. So obviously, when the growth plate is still visible, it means or it is suggestive that the age is less than 20. The patient has not yet achieved the skeletal maturity. So it means or it is pointing towards the chondroblastoma as the diagnosis. On the other hand, if you look at any tumor which is present at the end of the bone, but the growth plates are already obliterated, that means you cannot see the growth plates anymore. It is suggestive of the giant cell tumor. So the for point number one, obviously, is the age. That means GCT in skeletally mature individuals, while chondroblastoma in less than 20 years of age. Second is, what are the most common bones to be affected by these particular tumors? The most common site to be affected by the giant cell tumor obviously is the distal femur. After that, there is proximal tibia, and finally, there is distal end of the radius. So this question has also been asked multiple of the times that in the upper limb, which of the following is the most common site to be affected by the giant cell tumors? While for the chondroblastoma, the most common sites are the proximal humerus, after that, the proximal femur and the proximal tibia. So these are the commoner sites to be affected by the chondroblastoma. Second is the physeal involvement. As we have already talked about, that in case of GCT, majority of the time the growth plate would be found to be obliterated, while in case of, so there is fused or obliterated growth plate in case of GCT, while in case of chondroblastoma, there is going to be still present growth plate. That means the physeal plate or the physis would still be evident on the X-rays in case of chondroblastomatous tumors. Next is the nature of the tumor. You see, the giant cell tumor is a benign tumor, but it is lying in the category of aggressive. That means it is aggressive benign tumor, which means that it is locally indulating. It is responsible for encroaching all the way up to the outer margins or the outer boundaries of that particular region of the bone. It is behaving like a malignant tumor, but locally, and to some extent, there is also a possibility of malignant transformation. 5% of the GCTs can be converted into a malignancy. And what are those malignant tumors in which GCT could get converted into? One is osteosarcoma, malignant fibrous histiocytosis. So these are the tumors in which GCT could be converted into a malignancy, and the possibility is 5%. Now, if I ask you one question, that is the GCT itself as a tumor can metastasize? So yes, there is also a possibility for the GCT as a benign tumor to metastasize. But there are two conditions associated with this metastatic phenomena. One, only the distal radial GCT tumors has the capacity to metastasize. And second is that the most common site to receive these metastatic lesions are the lungs. And there is a possibility again of 5%. That means 5% of the distal radius tumors, they can metastasize to lungs as a benign tumor, remember. So that is the discussion of the nature of the giant cell tumors. While the chondroblastoma, these are obviously the active type of the benign tumor. So they are usually less aggressive in comparison to the giant cell tumor, and they are obviously not showing enough any phenomena of metastasis. So these are the 2 points that you have to remember related to the nature of the disease. This question has already been asked in INI CET examination in 2023 that GCT as a benign tumor has a possibility to get metastasized. So yes, there is a possibility for distal radial giant cell tumors. 5% are the possibility that these lesions can metastasize to affect the lungs most commonly. Coming on to the x-rays, because ultimately what they ask you are the x-rays, and they ask you the diagnosis just by putting the x-rays on. Now, as all of you know, that the named, that means theoretical finding for the giant cell tumor is the soap bubble appearance. But you should not identify this giant cell tumor by using your artistic imagination that is this lesion appearing like a soap bubble or not. Simple. It is the epiphyseal tumor. Point number one, that the lesion is epiphyseal. It is a lytic lesion because of the increased osteoclastic activity. There will be breaking down phenomena of the bone. So it results in the lytic expansile lesion of the bone at the end of the bone. And if you look at the growth plate anywhere, then you will not find any growth plate. That means all the growth plates are already fused. So there will be a fused growth plate. So when you combine all these features, you can easily reach the diagnosis of a GCT. Simple. That means epiphyseal tumor, growth plate obliterated, answer is GCT. But if the same epiphyseal tumor is present along with the growth plate, that means growth plate is still visible. That means you are looking at the epiphyseal tumor of immature skeleton, and here it is pointing towards the chondroblastoma. So as simple as that, this is how you will identify the X-ray findings for the GCT and chondroblastoma. So that was the fifth difference in between the two. And majority of the times, your question is asking about the X-ray differences only. They will give you an X-ray and then they will ask you what is the diagnosis for this particular one. Now, as far as histological differences are concerned, both of them, the giant cell tumor that is osteoclastoma as well as the Codman tumor that is chondroblastoma, they uh, are characterized by the presence of the multinucleated giant cells. The only difference is that in case of GCT, there are numerous giant cells which are scattered in the stream of mononuclear stromal cells. But the number of the giant cells are numerous. That means too many giant cells with scanty cytoplasm. This is how you will identify a giant cell tumor. One of the characteristic biopsy finding for chondroblastoma is that there is a presence of chicken wire calcification. That is a small granular pattern of calcification, which is obviously not seen in this particular image. And this is how you will differentiate it from the chondroblastomatous tumor. On the other hand, in case of chondroblastoma, you will be seeing numerous but less in common, means less in number. Although numerous but less in number, giant cells are present, and these giant cells having multiples of the nuclei are scattered among the stromal cells having a single nuclei. But if you look closely, then there is a presence of the granular calcification pattern scattered in between. And this is the classical feature for chondroblastoma known by the name of chicken wire calcification. Theoretically, this thing has been asked multiple of the times, but as far as your questions are concerned, in today's age, there is also a possibility that they might give you a clinical question, they might give you a X-ray, and they also might give you this histological image, and then they will ask you what is the diagnosis the patient is suffering from. And finally, the management. You see, uh, a GCT, a giant cell tumor, which is a aggressive sort of a benign tumor, has to be curated. That means there is an extended curettage performed. That means removal of the normal margins also. And once you remove that region of the bone, a large region of the bone, then that gap which is created by you has to be filled. Now, that gap is filled either by the placement of the graft or by the placement of the cement, the bone cement. Now, it depends whether you augment this procedure with the fixation device or not. For example, if you look at this image, here there was a placement of the GCT, but it was filled with the bone graft, cancellous bone graft, and after that it was augmented with the distal femur locking plate. Why? Because of the weight bearing zone. It is a weight bearing zone. The articular congruency has to be maintained. In order, the patient has to bear weight back onto the limb. Similarly, in this case also, the proximal tibial GCT was removed and the cancellous graft was placed, and it was then augmented with the placement of the fixation device, that is proximal tibial locking plate. But in this image, when you have removed the GCT, after that the gap was filled by the bone cement, and then there was an augmentation by the placement of the plate fixation device, and here also instead of the graft the cement was placed and it was fixed by the fixation device, that is proximal tibial locking plate. So it all depends upon the personal choice of the surgeon and whether to make the patient rehabilitation easier. So these are the choices that you have to go through. So surgical excision obviously is considered to be the first choice of the management for giant cell tumors. Now, as far as chemotherapy is concerned, there is a provision that denosumab, which is a rank ligand inhibitor. You already know that denosumab, what is the function? You see, normally this osteoblastic cell is having two types of the receptors. One is OPG, that is osteoprotegrin, and the other one is rank ligand. Now, if there is any stimulus which activates this OPG, then it results in the overactivation of osteoblastic cells. That means there will be mitotic activity of the osteoblastic cells. But in case if there is any stimulus which activates the rank ligand, then this osteoblast will be differentiated into osteoclast. And this is exactly what the pathogenic mechanism for GCT is, that you have to prevent this excessive osteoclastic activation. And how it will be prevented? By blocking this rank ligand. How this rank ligand is inhibited? By the placement of the denosumab. So denosumab in the dose of 120 milligrams subcutaneously is administered on day 1, day 8, then day 15, and finally the 28th. That means once a week dose, and once it is done, it has to be delivered every fourth week. So this is how it is being administered. Now, what is the function of denosumab? Can it cure the disease? No, it slows down the progression. Can it prevent the recurrence? Because GCT is having a very high recurrence. No, it cannot prevent the recurrence. It cannot 100% prevent the recurrence. It can just limit the progression of the disease. That is the function of the denosumab as a chemotherapeutic agent, which is used in case of giant cell tumors. As far as the management of chondroblastoma is concerned, it is very simple, and the answer for that question is curettage along with or without grafting. Curettage with or without grafting. So that is the answer for this question. So hopefully you have understood everything related to these two particularly important epiphyseal tumors. Hopefully you would be able to answer any question asked correctly related to this topic. All the best for your future examinations. Thanks for listening the lecture. In order not to miss any update related to this NEET PG 2025, please join our Telegram group. The link is provided to you in the description.